if I could just ask Atia behind the scenes to put the recording on, we can capture this for other participants who aren't able to join us. So my name's Sian Howell. I'm a GP in South East London, and for the last few years I've been the clinical lead for general practice access with the Healthy London Partnership team. Today about how to make local services work best for your patients. And I'm just going to start with a piece that I read this morning while I was having my breakfast, which is in this week's BMJ from David Oliver, and it was talking about how the tension at the moment between general practice and hospitals, and how general practices are feeling slightly overburdened from hospitals, describing themselves sometimes as feeling like the house officers, chasing up results and following up patients that really should be seen by secondary care, and how secondary care are complaining that general practice are sending up things that really should be seen in primary care. And there's a real sort of fractiousness at the moment. And I think that just reflects the difficulty we're all under, both in primary, secondary and other services. And David makes the good point that really at the moment, with things so difficult, we should be focusing on unity rather than division. And hopefully we can have a think about how we can better unify some of the services in today's webinar. Our patients don't see different commission services, they don't see different providers, they see a single NHS. And I think it's difficult for patients to understand the complexity of what goes on behind the scenes and how much activity has to go on to really join these services as well as we can so that they get a seamless journey. So what we're going to do today, we've got a number of speakers talking about how to use local services as part of an access program in general practice. We're going to be talking about the directory of services, the community pharmacy service, consultation service, how 111 connects, and an update on the enhanced access service specification. This session is being recorded and will be available on the HLP website. As I said, this is webinar number 4. The first 3 are available on the website, and you can also go to the website to book for the last session, which is next week, around making change. If we could go to the next slide, please. So why a London Access Guide and Manual? Some of you may have caught the short film, which is also available on the website. But really, the Access Guide and Manual talk about this sort of whole system approach to access, recognising that there are multiple components that need to be in place for a practice or PCN to offer good access to its patients, to their patients. The guide is shorter. It's really for the whole team to look at where your practice might want to focus their efforts. And then the manual has got lots more resources and is probably best for people leading on access improvements to dig into as they start to do access improvement projects. Both the guide and manual have an appendix with a great long list of suggested access improvement projects, small steps, large steps, data to use, and so on. So the webinars have kind of covered each section of this whole system approach. The first webinar looked at general practice activity, the importance of measuring what we do, trying to get the right balance of this very contentious digital versus face-to-face appointments, how to manage DNAs, etc. So please do go back to that webinar if you missed it. The second webinar, we looked at working with patients to provide the best possible access and really thinking about an equitable access offer that meets the needs of all of our patients, particularly those with very high need. Last week, we talked about the general practice team, the bedrock of providing a good access service to our patients. And today we look at how to use local services for patients. Next week, we finish with making change, actually deliver and make the changes that we need to deliver the access projects that we're talking about. So that's this idea of this whole system approach. If we could go on to the next slide, please. Oh, I think I was supposed to say as well, who it was produced by. So the London Access Guide has been produced by the Healthy London Partnership team with lots of GPs involved, and also with London-wide LMC, with the RCGP, commissioners, Health Watch were involved, and also the Practice Managers Association. So it's been a very sort of collaborative document. So access beyond the practice. If we could move to the next slide, please. So when you develop your practice access system, you really need to think about how to make all of your services work for your patients, not just your own service. When to signpost, how to respond when your patient's been seen elsewhere, and how the informations flow between services. If we get our messaging consistent, we're going to reduce the risk of patients being sent to lots of different places, make sure that patients have a more aligned and less fragmented offer of care, and that we get better value. And we're kind of searching for this nirvana of right place, right time, right care, right person, all of this combining to give the patient the right access. Now, we know that patients often access other services when they might be better seen in general practice, and they may come to general practice when they may be best seen in other services. Now, some of that is outside of our control, and the patients who very frequently come to you will probably be very frequently going to A&E and going to community pharmacy and other services. But there are some things that we can do. And so a consistency of messaging, and we talked in week 2, I think it was, about working with patients to develop a patient charter or welcome pack so that they can understand how to use your service effectively. And signposting patients to an up-to-date website, making sure that you've got consistent messages perhaps on your telephone or posters in the waiting room, and working with patients in your PPG to make sure that you are messaging in the right way for your patients. You're probably best working with the external organisations that you deal with most frequently. So we're going to hear a little bit later about working with community pharmacy. Those kind of, your community nursing team, these teams that you have very, very regular interaction with, this is the place that you really want to have a smooth and understandable pathway for your patients and information flows. If we could go on to the next slide, please. This slide just looks at the patient in the centre and really looks at where general practice sits in. So we, as I mentioned, the services we work very closely with are community services, social care, opticians, community pharmacists and dentists, all sitting very close to the patient. And then a little further out, you've got the 111 service that we're going to be hearing from later. You've got urgent treatment centres, A&E, outpatients, voluntary and third sector organisations, and GP out of hours services. Now, I think the out of hours space is particularly challenging for patients to navigate. It can be quite difficult to know because services seem to be set up quite differently, some for patient convenience, some for patient need. And if we can somehow get that signposting right and the information flows right for our patients, we can really make some of those decisions easier. So if we could go on to the next slide, please. So how do we make these information flows work well? Well, it's about making sure your team knows and has got the right information. And unless your team is well informed, it's going to be very difficult for your patients to be well informed. We talked a little bit about the practice website and then making sure that the information transfer between services works smoothly. And then making sure you've got the right resources for your patients in these places. This slide just breaks it down a little bit. You're going to have practice-specific resources, excuse me, perhaps your opening times and what services you offer. And then PCN resources, perhaps how to use social prescribing link workers. There may be some self-referrals and self-referral services you can signpost people to. Making sure your borough resources are up to date. Do people know where the local hospitals are, how to use local urgent treatment centres, for example? And there are some really good national resources, and we've included links for all of these within the guide and manual for things like the NHS UK website, when to call 999, and these may be sensible things to include on your website. So that was just a little bit of a rattle through of the context of trying to make sure that we have the right services and the right signposting for our patients. I'm now going to hand over to Andrew and Jonathan, who are going to talk to us about the Directory of Services as a tool. So thank you, Andrew and Jonathan.
Hi there. So my name is Jonathan Baker. I'm the Director of Services Manager that heads up the Directory of Services team across London. Andrew?
And I'm Andrew Cox, the Regional Director of Services Lead for London.
Great. Could we go to the next slide, please? Okay, so the Directory of Services has been around since around 2011, so almost 10 years. And it essentially underpins the 111 service and supports the 999 emergency clinical assessment service as well. So the DOS holds all of the commissioned health services and some other supporting services as well that are appropriate for 111 and 999 referrers to be able to refer to. The DOS is a national database, but we do have a local way of managing it so that we can ensure that patients are sent to services locally within a borough or within a registered area for patients. The DOS is managed across the whole of the 5 CCGs in London by the DOS team. And just to say as well, and we're going to come on to this shortly with Andrew, that the DOS is also fully integrated with the NHS Pathways clinical algorithm, which is the tool that's used by the 4 111 providers across London. The DOS does hold clinical data as well, which shows which skill sets a service offers, as well as which symptoms it can assess. And the DOS also facilitates direct booking into downstream providers, such as general practice. And I know that's going to be touched on by Rob as well on this call. And then as well, really clinical governance, is critical to ensuring that the DOS is clinically safe, and which we'll again cover as part of this presentation. And just to add as well, so the DOS also is linked to the NHS 111 online tool, which is the self-triage version of 111 to enable patients to access services. So our team as well, we kind of map that out, and we work very closely with commissioners and the clinical leads from the 5 CCGs to ensure that, the services that are available reflect commissioning intentions and what's appropriate for patients locally. Next slide, please. So this is more of an overview, just to kind of show that the directory of services isn't just a list of services. So you can see here that it requires quite a few different elements in order for the directory of services to trigger a result. So when the referrer, whether that's a health advisor or a clinician, has gone through the Pathways algorithm, it requires all of these elements to be able to trigger the DOS. So the obvious one being a postcode, so that you can then return a service close to the patient. In some cases, you need to include the GP registration, because there are some services that are restricted to where you're registered. Age and gender, again, very important, because some services are age specific or gender specific. And then we have the clinical profile within the DOS, which essentially outlines what that service is commissioned to do from a clinical perspective. So it could be, chest pain, but it's primary care level. And then the time frame, which in the DOS world, 111 world, we call a disposition or a DX code. So that is the time frame that the patient should be seen, which has been determined by the Pathways algorithm. And then there are different referral roles as well in the DOS, depending on the referrer, which again play a factor. And then we have the capacity status tool in the DOS. So if a service is at capacity or almost at capacity, that is flagged to the referrer. And in some cases, if the service isn't able to accept any patients, that service won't return for the duration or the period that the service is unable to accept any more referrals. And then the end point is where you have either the direct booking, or it could be booking into a clinical queue for a callback from a clinician. And that is where we map the code that essentially triggers that direct booking outcome. And then the search ranking, that is where we're able to actually say, well, this service is only for a particular area. So, for example, we could say the service covers the whole of London, or it could be that it's for a particular borough, or it could cover an ICS, or you can choose how you want to show that service, and that works alongside the GP registration as well in some cases. And then the only return if open is used where, for example, you have a service such as GP out of hours, where they have a clinical queue that isn't monitored until they physically open. So it means that where you have a longer disposition time frame, let's say it's 6 hours and it's still the afternoon, it would mean that service wouldn't show to the referrer until it got to the actual physical opening time, so there was no risk of the patient deteriorating whilst they're waiting for the service to open because they're stuck in the clinical queue. So that's how we use the only return if open. And then the catch-all event is triggered where the DOS has been interrogated within NHS Pathways, and it hasn't been able to find any match based on what we've just discussed, in particular the symptom group and symptom discriminator and disposition that's appropriate. So it returns the 2 nearest emergency departments to say to the referrer. You know, there was nothing else available. So here are the 2 nearest EDs, but there are local protocols in place that mean that would then be dealt with by a clinician in the call centre to find a more appropriate outcome. And then the ranking strategy, which we're going to come on to shortly as well, is the commissioner part of the tool, which basically says which services are the most appropriate to be referred to first. So if you kind of think of it as a spectrum, you've got things like pharmacy that should always try to be referred to as the kind of first option, followed by other types of primary care, and then things like your urgent treatment centres and EDs as the last resort. So that's how the ranking strategy works. So that hopefully gives you a flavour of the DOS in the sense that it's not just a list of services. Next slide, please.
So this is over to me, I think, Jonathan. So Jonathan mentioned earlier that the directory of services isn't a standalone solution. So it's also actually linked. Well, it's linked to the solution that everybody knows as NHS Pathways. That's a clinical decision support solution that 111 staff, that includes health advisors and clinical advisors, utilise and contains a whole range of clinical algorithms that determines where the patient goes after they've been assessed by a 111 user or staff member, sorry. So when the patient rings 111, essentially the NHS 111 service captures all of the information in this area here, including their name, address, contact number, date of birth, etc., and whether they're a registered GP with a GP. And then the information about the patient is pulled from the national spine. And then once that's all collected in the system, which is in London, the Adastra solution, the patient will be taken through a clinical triage through the NHS Pathways tool, and that is kind of split into 3 key areas. So module 0, which is the first part of the solution that rules out life-threatening illness. Module 1, which is the kind of HA or health advisor element of the solution. And then in some instances, if they need to be referred to an NHS or signposted to an NHS 111 clinician, they are given kind of a further triage from an NHS 111 clinician. But if the algorithm determines that the patient can go to their GP through the health advisor assessment, then that happens there, at which stage the patient is referred via the directory of services, essentially. So that's if you go to the next slide.
Okay, back to me. So the CCG ranking strategy, which I touched on already. So this is the commissioner part of the DOS. So this essentially allows the commissioner, like I said, to determine what would be appropriate to return first. And again, the clinical appropriateness plays in here as well. So, for example, if you end up with an outcome in Pathways that's of a higher acuity, it will obviously come back with, for example, an ED, or it could also trigger an ambulance depending on the acuity. But again, there is a sign-off process for this, and the commissioners and the clinical leads are responsible for that within each of the CCGs in London. Next slide, please. So this just gives you a bit of a overview of what a ranking strategy looks like. So you have all of the service types, and these service types are part of the national DOS. So we have to rank them based on how they're utilised. So, for example, if we have service types that we don't really use, then they tend to go into the lowest. So they don't appear in the results in at all. And then those services that we would want to be returned first, we would rank highest, and then so on. So you can see you've got pharmacy in the top there, GP practice ranked 3rd, and then you have, like, for example, your GP access hubs, mental health, urgent treatment centres, and then EDs and so on. So every borough in London has a different ranking strategy depending on what services they have available or what's appropriate for 111 or the 999 emergency clinical assessment service to be able to refer to. So hopefully that gives you an idea of what ranking looks like. And this is reviewed very regularly as well with commissions, especially as new services are commissioned or we have new service types that come on board. So, for example, we've got a new one that's just gone live for urgent community response, and that's all about trying to improve access to the 2-hour crisis services. Next slide, please. So I won't go over this because I'm conscious of time, but this again gives you can read this in the pack, but this gives you an idea again about the importance and the rules around the ranking strategy. Next slide.
Yeah, this is me. I'll just spend sort of a couple of seconds. So as and when the user goes through NHS Pathways, they essentially reach a combination of coding. So that's a symptom group, so symptom discriminator and disposition code. The symptom group essentially is the kind of the clinical associated symptom for why the patient's caller. The symptom discriminator is the service type and the service skill set that's required to treat the patient, and the disposition is the time frame that's required to teach the patient to treat the patient. If you go to the next slide now. And then lastly, it's just to say that there's a robust clinical governance process behind the Directory of Services, which includes kind of regular review and sign off with all of the key stakeholders that include kind of the commissioning leads and clinical ICS clinical leads, as Jonathan mentioned before. And we'll share all of this information in the slides so that you can see it. And I'm just conscious that we're at time now. So yeah, any questions, please put them in the chat, and me and Jonathan will help to answer them over the web. Thanks very much.
Thank you.
Andrew and Jonathan, thank you. That was really helpful. I'm always, I guess, I don't know if you could both turn your cameras just back on for 1 second for a question that I've got for you, because I've always thought this would be a really helpful tool to have in general practice, because there is so much information in it. Are there any plans for, because there's so much, for a general practice reception team to be able to see what pharmacist is open when and how the UTC is doing? Are there any plans to share this in general practice? Because this would be a really useful tool.
Yeah, so there are different versions, and Andrew, chip in as well. So we have the MyDOS tool as well, which is linked to the DOS, which is in the bigger pack that is going to be shared after this call. So we do have MyDOS, which can be rolled out, and that has all of the pharmacies, all of the same information in the DOS. It's just presented in a different way. And what we can do is we can actually work with general practice to design it to suit their needs in terms of how they access it and how it looks in terms of the button configuration. But there are other ways of also accessing the DOS through other versions, which Andrew, I don't know if you want to touch on. But MyDOS is the quick win.
Yeah, I think it's probably another call to be honest to talk about this, but absolutely, I think if there's any interested kind of stakeholders that would want to do that, then please get in touch with myself and Jonathan, and we can share like all of the options available to you essentially.
Great, yeah. Thank you both very much. We will, yes, please do put any questions, thoughts, frustrations in the chat. We'll try and address as many as we can at the end of the session. Jonathan and Andrew, I know you've got to go, but we can always forward on those questions and put them on the website, and the slides will all be captured on the website. So thank you both very much. Thank you both, thanks. I'm now going to hand over to, and welcome and hand over to Hamad Patel, who's going to talk to us about the relatively new community pharmacy consultation service. Some people may have experience of this, but some people less so. So Hamad, thank you very much, and thanks for talking us through this one.
All right, thanks for that, Sean, and thanks for inviting me to speak to today. So my name is Hamad. I work in the NHS England Pharmacy Integration Team as a regional integration lead, and I cover the London region. I also have experience with primary care, and I still work as a prescribing advisor in North Central London CCG also. So the purpose of my presentation today is to highlight the community pharmacy consultation service is one of the services that your local community pharmacy will be offering, and in particular the GP referral pathway into this service and the role it could play and it can play, and we've seen it play in other areas of the country and in London in access improvement. So rather than talking on too much, I'll start with a small animation that covers the service on a high level. If you can play the video, please.
Referring patients with minor illnesses to community pharmacies can help to reduce the pressure on general practices and other parts of the NHS. The NHS Community Pharmacist Consultation Service, or NHS CPCS, provides patients with a same-day consultation with a pharmacist at a time and place convenient to them. Since October 2019, patients have been able to access this service via a referral through NHS 111. Now, with 94% of all NHS pharmacies in England registered to provide the CPCS, general practices across England can also start to offer referrals. The CPCS is proving very popular with patients, pharmacists and GPs who are positive about its convenience and speed of access. So far, more than 200,000 patients have been helped. Pharmacists are experts in the use of medicines and can provide advice along with quick and effective treatment for a wide range of conditions. Around 90% of patients referred by their general practice are helped successfully by the pharmacist they see, without any need for an onward referral. At general practices, the service will normally be accessed through a member of the reception team, usually the first person the patient speaks to. Patients are asked a few basic questions about their condition, and where appropriate and with their agreement, the practice reception team will refer the patient for a consultation for minor illness with a pharmacy of the patient's choice. In some general practices, this may all happen electronically. A range of minor illnesses are commonly seen through referrals to the CPCS, such as sore throats, aches and pains, sore eyes, upset stomachs, allergic skin reactions, and mouth ulcers. The consultation can be carried out over the phone, by video call, or the patient can visit the pharmacy where necessary. The pharmacist will check the patient's NHS summary care record for any information about existing medicines before providing their clinical advice and any recommendation for treatment. This may include the purchase of an over-the-counter medicine. Where appropriate, the pharmacist will report the outcome of the consultation to the GP practice, and if symptoms do suggest something more serious, the pharmacist will refer the patient for an urgent GP appointment or escalate to an appropriate care provider. Most people are within easy reach of a pharmacy, and with many open in the evening and at weekends, the NHS Community Pharmacist Consultation Service is offering increased convenience and choice, while freeing up GP appointments for patients who may have a more urgent or complex need.
Thanks for that. So as the animation covered on kind of a high level what the service represents, and as the slides come back up, we have a few of the key aims of the CPCS as a service itself, but particularly the GP referral pathway. So the service itself, aims to alleviate pressure on general practice and other care settings, urgent care settings, improve access for patients, which is obviously the theme of today, but also importantly promote self-care. We want patients to have a good experience through the service and to help establish community pharmacy as the first port of call for minor illnesses. The last bullet point on this slide is particularly of value too, where the success of the service in implementation not only utilizes and depends on existing relationships, but we envision it to help build on and strengthen relationships between general practice and pharmacy also. At the top of the page is just a note there, as you may be aware, if you've heard of this GP CPCS service previously, that implementation, although it's a nationally commissioned service, is nationally supported, but it's being really locally led and regionally implemented. Can I have the next slide, please? The next slide, please. Thank you. So as I've mentioned, the CPCS service via the GP referral pathway covers minor illnesses and low acuity conditions, those that you'd expect to be treated with either simple advice and or over-the-counter items. There's a summary of some of the conditions here in this kind of simple aid memoir, and it covers the general range that your community pharmacists are used to seeing on a day-to-day basis. Importantly, also on this slide is a point about how practices and PCNs have the autonomy and the ability to determine their specific exclusions and inclusions with the referral criteria for the conditions that they will be referring for. Although all of these conditions have gone through the robust clinical governance kind of sign-offs at a national level. Have the next slide, please. So again, this is a high-level overview of the service model itself, whereby the patient initiates contact with the GP practice, and we know that's either via more traditional means of face-to-face and telephone, but more increasingly via online consultation routes. There's a step in there where the GP practice ascertains whether the patient presenting to them is appropriate for referral to a community pharmacy. And again, that may be through more manual processes or using other clinical decision support making tools that are available to the GP practice. That case is then referred across electronically through a digital secure route through to the pharmacy. And again, there are a number of options of achieving that. That ranges from using NHS Mail and clinical templates in your GP systems to other bespoke standalone systems. And we've seen uses of a wide range of options across the country. That referral then lands in the pharmacy, which will then start the consultation process off by initiating contact with the patient and through to the choice and convenience of the patient, whether that's face-to-face, over the phone, and again, more increasingly video consultation. That consultation would include the pharmacist using resources such as summary care record, referring to resources such as the NICE clinical knowledge summaries, and run through a consultation with the patient, making sure to capture any red flags and signpost appropriately. The pharmacist will then offer the most appropriate advice, over-the-counter treatment, and if needed, an appropriate escalation to a more appropriate care setting if needed. But again, it's important to note that's a facilitated transfer. The patient is not left by themselves. The pharmacist would help to ensure that the patient is seen in the escalated care setting, whether it's the GP practice, A&E, etc. Again, there's a point on this slide to mention about the flexibility and autonomy for practices and about how best to adapt the service to their needs, their ways of working, and also importantly, their existing infrastructure. Can I have the next slide, please? So why is this important now and why are we speaking about it on this webinar? So we're all too aware of the unprecedented pressure and demand of general practice and primary care and all of the NHS. But this service gives us an opportunity to redirect approximately the estimated 5 to 10% of this activity into community pharmacy, which will be a very play a very important role as we enter into the winter period. And as again is the theme of today, plays into the access improvement agenda about the person seeing the patient seeing the right person in the right place at the right time. So in light of the opportunity, there have been indicators and incentives added to the PCN Impact and Investment Fund. And for the rest of this financial year, that means a PCN working collaboratively to develop a local plan to implement the service. And from next year, it would be depending on the volume of referrals being sent through. Can you have the next slide, please? So what's the impact that we've seen and how is it going in terms of implementation? So during the evaluation of national pilots that ran for quite some time, unfortunately, we did not have pilot sites in London, but we had them across the rest of the country. We saw that approximately 9 out of 10 patients referred from GP practices to community pharmacy were successfully seen in community pharmacy, and that consultation was closed in the pharmacy without any further involvement of another care setting. So whether that was primarily just through simple advice and guidance, whether it was a sale of over-the-counter medicine, where available, potentially a supply through a locally commissioned minor ailment scheme or a PGD service, and approximately 1 out of 10 cases being referred back to the GP practice. But as I've mentioned, it would be a facilitated transfer for that patient. We also had great feedback and positive feedback and great high levels of acceptability from patients and GP practice staff. So as you can see on the slide here, many reporting that the referral process was easy or very easy. So as I mentioned, the CPCS was a existing service, primarily via the 111 route, and the GP Pathway launched last year. Implementation has undoubtedly been affected by obviously the pandemic and lack of capacity and the vaccination program, but we've seen actually just over now 60,000 referrals nationally, and 887 at least practices, almost 900 practices that are actively live and referring. A larger number of practices are in the process of gearing up to go live. But as we can see, for the numbers for London, there's still it's quite a significant scope and opportunity there to be involved. Have the next slide, please. So what are the next steps? If you want to learn more about the service and how it can benefit your practice and the way you work and your patients, I'd very highly recommend the Future NHS PCN workspace, where there's a dedicated section to the community pharmacy consultation service. There's a wealth of resources on there, the toolkits, case studies, and also recordings of all the national webinars that we've run during the past year. Locally, in terms of implementation, get in touch with us at the London region. But more importantly, on the ground, the stakeholders that have been playing a hands-on role in implementation and supporting practices are your local pharmaceutical committees, and we can give you the contact details for them if they haven't come forward themselves. Your local community pharmacists, particularly the nominated community pharmacy PCN lead, who may already be in conversation with your clinical directors, your CCG Borough Medicines management teams who've also been playing a role, and also your practice and PCN clinical pharmacists who may have previously worked in community pharmacy and have a better understanding and can play a role of how community pharmacy can support your practice. I think that's my last slide. Yep, so unfortunately I can't stick around for the Q&A today, but if you have any questions, please pop them in the chat box and the team will get the questions back to me. And please do reach out to us on our London regional contact email, and we can get the ball rolling for you. Thank you.
Hamad, thank you. Just stay, if you could stay for 1 second, because there's just one question which I think you could probably answer, which is from Olivia. It says, does the practice have to pay for this service? I think I'm pretty sure of the answer, but it'd be great if you could answer it.
No, so the service itself is free. There are a small number of referral solutions that are not necessary for delivery of the service or taking part in the service, and they would need to be procured. But there's definitely no barrier, a financial barrier to entry into the service from a practice perspective. Great,
thank you. I mean, I think this is a really practical solution which is kind of ready to go now for Londoners. And if this could take away 5 to 10% of activity of minor conditions, that would be, you know, a massive help for people. I think there's also a need for practices to make staff available for training, and you know, there's a degree of needing to get up and ready for this. It's not, there's a question here about referral via ERS. No, it's a different referral pathway than ERS. And there are different ways of referring into the system. So I think probably the best thing to do is to go to the resources that Hamad has shared, because there are there's kind of connection, different ways of connecting into the service, and different practices are using different things, but not via ERS. But a very practical thing. So do connect up with the team, and this could be something really useful for your practice and for your PCN. Thank you, Hamad. I'm going to move us on now, because we're running really late, I'm afraid. Very bad sharing on my part, but I'd like to reintroduce Rob Ballantyne from the regional digital team, who's going to talk to us about 111. I think we are all seeing more and more 111 slots and patients popping into our surgeries, and Rob's going to talk about some of the stuff that's going on behind the scenes to make that happen. So thanks, Rob.
Thank you, Sian, and thanks for the opportunity to present today. If we just go to the next slide, Atia. So firstly, this is a real privilege actually to come and speak to you today, because this is a huge success story that's happened across London over the last 18 months. There has been a system-wide transformation in relation to the interface between 111 and primary care, and I don't need to say that. The evidence is on the graph. So the technical enabler of this deployment, of this transformation, has been the deployment and the configuration of 97% of London GP practices with GP Connect, which is a program that I've led, and we've with ICS colleagues across the region. But really what's kind of underpinned the change to make this land and make this stick has been the cross-system engagement between primary care, 111, the LMCs, both London-wide and local LMCs, DOS colleagues, we had Andrew and Jonathan on just earlier, NHS Digital and many others across all 5 London ICSs, and I'm proud that this transformation has occurred across all 5 ICSs. So the graph in the middle of the slide just shows the transformation over the time. So that shows the number of bookings from 111 into GP in hours over time. And you can see that over the last 18 months with March 2020, I'm sure, is a month that will resonate with all of us for the rest of our lives, probably. But the COVID was a real catalyst. And the ability for 111 to book patients back into their own general practice during the pandemic, when 111 demand was particularly intense, was a massive system-wide enabler, as it were. I was just doing some maths just while the other people were presenting, and there's been a 3,162% increase in bookings between March 2020 and August 2020, which is August 2021, which is the last data point on this graph, which is pretty significant, I think. So why is this important? So the ability for 111 to book patients with a primary care disposition or a primary care need back into their own GP practice is beneficial for both the patient, as it means that they're seen in the most appropriate healthcare setting for their need. But, you know, your GPs, you know your patients, you've got access to their records. But it's also beneficial for the system because it prevents inappropriate flows of patients from 111 into alternative care settings that aren't as aligned or, you know, appropriate for their needs. So that would be, for instance, co-located urgent treatment centres and EDs, which are a key pressure point both for now and during the winter period. So I just wanted to stress the importance there. So the next slide, if we can go on, please, Atia, is how are we actually configuring this within the GP practices, and what can we do? What can we look at both now and potentially over winter, where we know the whole system will be under significant pressure? So the way that GP practices are being configured is that GP Connect means that they have specific bookable slots that are embargoed, that are available for 111 to book in. But the challenge that we do still face in London is that there is variability in the way that those slots are offered, and that doesn't always align to the pattern of 111 demand. For example, there's sometimes practices are making slots available only in the morning, sometimes there's an inconsistent offer day to day, and sometimes there's not really enough slots available to meet the pattern of demand. So I understand and recognise that general practice is under a huge amount of pressure, and there's probably significant good reason for that, but we really need to try and make as consistent a downstream offer as we can from 111 within general practice. So what we are encouraging is that practices transition to a GP Connect work list approach. So this is and there's some screenshots on the right hand side of this slide of what that looks like. So this is the nationally recommended approach, and is the approach utilised in all of Southwest London, which has really good outcomes for its patients that have a primary care need that come through 111. It's also utilised by pockets of other GP practices and other ICSs in London. So the use of a work list, what it does is essentially, instead of appointments embargo for 111 being sort of randomly slotted in within your existing appointment book, you essentially create a separate work list with slots made available throughout the day for 111 to book into. So the idea is that these slots are evenly spread to kind of manage or sort of better align with the unpredictable pattern of 111 demand. So that's the concept, as it were. It's a very quick overview, but you can see the screenshots, and I'm always happy to, I've been talking about this for a long time. I know this slide at the back of my hand, so I'm more than happy to talk about it privately and separately from this call. So we understand that setting up practices with a work list is beneficial for 111 because it essentially improves the alignment of the capacity made available through that's GP contractual capacity with the demand coming through 111. But there's also benefits to the GP practice itself, which I'll just talk through now. So firstly, better outcomes for registered patients. for your registered patients who call 111 with a primary care need, there's an increased likelihood through that better alignment of capacity and demand, which I've just said, that patients will be booked back into the most appropriate healthcare setting for their needs. So 1, better outcome for the patients. 2, because of the way the appointment slots are set up, practices do not have to reclaim back appointments that are not booked into, which they do if they're set up via their appointment book, which I'm sure, I'm not a practice manager or don't work in a GP practice, but I'm sure that colleagues on this call that do would say that that's an administrative burden, a boring job, and not particularly efficient. With a work list, that's not required. It's just a separate list. They're either booked into or they're not, and the existing appointment books can operate as per usual. And thirdly, practices can deal with the referrals as if the patient called the practice. So the patient is triaged and managed according to clinical need. The initial triage, in a way, has already been done by the 111 provider, and there's a PEM message that's sent from 111 to the GP practice that kind of explains the key points about the patient's disposition, why they've been booked in. So the key point here really is that it allows or empowers, as it were, clinicians within the practice to manage the patient according to their clinical need. So instead of the patient being booked into a specific appointment slot and having to be called back or spoken to at 3 p.m., which may not fit with your operational workflow, as it were, the patient's booked into a work list. You can monitor, have a look at that patient, think, okay, I'll speak to them at 5, or I'll just give them a call now and I'll book them in a week's time. And that's one of the kind of key benefits of this approach, and one of the reasons why I'm talking to you about it today. So if we just go to the last slide, thank you. So I have tried, this is a massive piece of work, a massive interface, but I've tried to distill it down really to the key messages. So the first thing is we are doing a pilot across London within each ICS of GP practices operating a work list approach, because we want to get some learning from it. We already have Southwest London have this in place. They always enable their practices this way. So we've got some fantastic learning from Southwest London, but we want it from other localities. So any practices that are listening to this and think, okay, we can understand why you want to do that, we're interested, please let me know, or please let your local GP Connect lead know, and we can take that forward. So we're doing a pilot to gather learning both of quantitative feedback, so how does this impact on the number of bookings, how does this impact on the number of referrals from 111 to UTCs for patients that shouldn't really go there, etc., etc. And also qualitative feedback. How did it feel within the practice? Did it, how did you get on with managing the work list? What was the impact on operational workflow, etc.? We want to really kind of build our picture and understanding of this. And this is a two-way street between general practice and 111. It's an integrated system overall. That's what we're working to achieve. Secondly, GP Connect utilization program. So we're looking at kind of our marginal gains here. So how can we look at the way appointments are scheduled and see if we can tweak them to better align with the demand, as I've spoken about, and also work with the wider primary care landscape. So this is not all about GP in hours having to pick up all of this demand and all this pressure, not at all. We're working with extended access hubs to try and standardize their offer for 111, and also working with the complex landscape that Sian alluded to of GP out of hours. We're really trying to build a sort of 24/7 downstream primary care offer from 111 for patients. So patients with a primary care need, 24/7 offer that is robust for this winter and manages the demands that we think the system will be under. Thirdly, as I kind of alluded to really, but quantitative and qualitative feedback to determine any system-wide recommendations or solutions to continue to improve this interface. And this is really important. We've worked really hard now regionally and loads of different levels to try and improve and join up this 111 and primary care more and more. And we want your feedback. We want to learn about how it's going, the number of bookings, the appropriateness of patients. It's the only way we can just put continuous improvement cycles in and really drive developments and transformation across London. And the final thing is we recognise that the PEM, so the post-event message, the kind of communication that comes into general practice when someone's been booked in, is suboptimal. It hasn't been improved for a while, really. So we're working with the national team to try and make some improvements to that so that it's more informative and that the information on it is a bit more like you would see from an online consultation tool, such as just a bit clearer information about the patient, why they've been booked in, etc., so that it informs clinical decision making and you're not having to sift through loads of detail. So that's some of the key points really about the interface. My details at the bottom, please let me know if I can help with anything. And there's also colleagues within your own ICS that are leading on this work.
Rob, thank you. That was really helpful. And I think, again, it's an example of a very complex IT tech. The tech stuff's really quite complicated behind it. And I guess, and then the point from there's a couple of things in the chat actually that we could pick up on, because I think that it sounds like the tech's kind of in place, but sometimes the quality of the referrals isn't what people would hope, and there's still some smoothing out. I'm just having a look. So patients calling 111 on a Friday, getting booked in on a Monday, which doesn't quite work, or patients being told that they need to be seen within 2 hours and not. So it's really good that you're going to be doing this feedback.
Yeah.
I just wonder if there's any plans for a kind of more immediate feedback, that kind of like something's gone wrong straight away.
That's a good point. So there is something called a health HCP form, so a healthcare provider form that each practice should have, that essentially any referral that's booked in from 111, there's a form. I know it's laborious, but it's the only way that it can be properly audited, that the practice fills in to say the patient was booked in from this provider and the reasons why it was inappropriate, and then that goes to a kind of generic mailbox within the provider, and they have to respond. And it sets off an audit trail within that provider. So whilst it's important for me to hear it, I can't actually influence the change as much as if feedback goes directly to the 111 provider that made the booking. So that's the first thing I'd say. Yeah. Second thing is around the disposition time frame. So when you say a patient's been told that they need to be contacted within 2 hours, one of the advantages of the worklist approach, which I was sort of alluding to, is it empowers the GP. So the patient's booked into one of their slots, they can review that patient and think, actually, I'll speak to that patient in 4 hours. I know the patient, I know they're okay, I can see their records. I've got 4 other things that are of higher priority and I can contact them, because the patient is actually told by 111 that they will be contacted at some point during the day. The patient isn't told you will be called at 11:20, for example. So it kind of puts that empowerment back on the GP.
That's really helpful. Could I ask, it's really great that you've shared the slides. I wonder, can you just tell me the name of that form again, and I'll put it in the chat?
It's an HCP, healthcare provider feedback form.
Feedback form. And if practices don't have that, where could they get hold of it?
So I've got the LAS one, but essentially if you ask me, then I can coordinate with the providers.
Okay, so if you haven't got that if you haven't got it or don't know how to use it in your practice, Rob's email is in the chat and he will signpost you to the right place. You're going to be inundated, Rob, now. But don't send Rob the individual complaints, because he doesn't know what to do with somebody who's been... Not that you don't know what to do, but it's not going to be as impactful.
Yeah.
Yeah, exactly. So it's a bit like doing quality alerts when the hospital something goes wrong. It is tedious to do, but I guess it's a new service. There will be hiccups. You're quite right in one of the comments about using the algorithm. It doesn't always translate into something meaningful. And I think this is also one of the difficulties when we talk about information flows. You're never quite sure what the patient's told, what the story is, and actually this is why it's really important to have kind of consistent messaging from our end, so that we are very confident that we know how NHS 111 works and that NHS 111 works with us. So I guess this kind of connection and evaluation is really key. So thank you for that. I'm doing really badly, but I'm going to hand over. We've done the kind of chat as we've gone along a little bit. I'm going to hand over now to David, who's going to talk to us a little bit about the enhanced access service spec. So David, over to you.
Thank you, Sian. And so my name's Dave McKinley. I'm a program manager within the Transforming Primary Care team. So this was just a slot that we'd put in because we were hoping that the enhanced access service specification was going to be published around about now, and we're hoping to be able to give you a very short précis on what the operational detail included within it was going to include. Unfortunately, it isn't available just yet. But what I can say around it is that whilst it will be introduced obviously the specification will be published shortly, and whilst the service will be introduced next financial year 2022 and 2023, We are aware that the national team are considering the implementation timelines. So just as a bit of background, obviously, it's the current extended hours access service and the CCG commissioned extended access service that are going to be merged into one consolidated single enhanced access service. And as soon as we have further details about that, we will obviously let you know and share that information. Next slide, please. So what the national team are going to do to support this is, well, the rollout of this company and accompany the specification is going to roll out a package of support. One item of which is going to be increased and likely to be increased slots on the Access Improvement Programme. For any of you that aren't aware of the National Access Improvement Programme, it's delivered by the Time for Care team. They work with nominated PCNs and practices to review local access systems, identify quality improvement areas around access and support them through them. Now, what we are doing and what we've been working with them to do is to put on a series of 3 90-minute free practical webinars around capacity and demand mapping to help practices understand their capacity and demand. We should have the time slots and the link and the further information for you very shortly. And what we'll do is we'll follow up after this webinar and circulate the details. You're welcome to join, and all you have to do is register, but there is an expectation that if you register for them, you join all 3 because they are linked. That's all I have to say, but there will be a further package of support that we will provide a further update in the due course.
Thank you, David. That's really helpful. I'm really sorry we haven't got that. We thought it was going to be perfectly timed. We have been told on several occasions it's about to come out, and it hasn't quite come out. So apologies, we haven't been able to share that with everybody today. I realise we've kind of done the questions as we've gone through. But I don't know if there's any, and there hasn't been. I think we've answered most of the stuff in the chat. And really, I think for the individual feedback on 111, I think it's to use the HCP feedback forms. David, we've got a couple of minutes. Any questions that have come in that we could try and answer for the people who are on the call?
Yes, when delegates registered, they were able to put in a couple of questions, and so there was a few that we can touch base on. There's 2 linked questions that we received. The first one is, how can we create patient confidence in utilising the wider system with the different offers, the community pharmacy, enhanced access, and other local services? And then linked to that, there was a separate question around how we can upskill general practice teams to appropriately signpost patients to the right service. I thought I'd open that up to everyone. I suppose the first thing to notice is that we've obviously we've got on our access guide webinar number 3, which is available on the HRP website. We actually have we did discuss the teams element, and there obviously is elements in the access guide as well.
I'm on mute, which isn't great for a chair. There's lots of stuff in the access guide and manual, particularly in the teams section. And the teams meeting is the one we had last week about making sure that you've got a really well-informed team and working with your patients to kind of recognise what the patient needs are. But if you have, we talked in the patient webinar about having a patient chart or a welcome pack, which kind of sets out your stall, making sure that you've got an up-to-date website. And thinking about what the content of that would be. And there's also kind of lots of really good training for reception staff about signposting. So perhaps if you sign up for the community pharmacy consultation service, part of that will be training your reception staff on what is available and recognising that is an investment. It does take time, but then hopefully that will pay off as you start to see patients diverted to a different service. Maybe coming together as a team to really understand 111 and work out how you're going to feed back so that your front desk team particularly feel confident that they know where they're referring people to. We talk in the manual about urgent treatment centres. Find out where your nearest one is and what do they offer? Do they have an X-ray machine? Do they see fractures? For example, I know our urgent treatment centre won't see anything to do with legs, won't X-ray faces, but they will do arms and upper body. So it's kind of just worth knowing and having a really good idea what those local services are and having team meetings so everybody understands them. It does take time. There's no shortcuts to that, but then hopefully that will start to pay off. I realise that's taken us kind of neatly up to 1 minute to 6. I'm sure everybody is happy to have a minute of their life back. And then hang on a minute, we've got one more question in the chat. Let me just have a look. Oh yes, I think Rob's just been answering some questions in the chat for us, so thank you. Thank you everybody for joining. Please do come next week when we're talking about making change. We're going to talk about all the different projects that we've discussed over the last 4 webinars, but how you can use change methodology, how you can use data, and how you can work with your team and patients to implement the changes that you want to in your practice and in your PCN to see improvements in access. So thank you all very much. And if the team could stay on, that would be great. Thank you. Good night.